Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
And my connection is a little slow, but it'll be up. There you go.
Yeah, this is an article that talks about measles uh, being manifest itself in California as a consequence of an unvaccinated child who attended the program and exposed it. So the worst dreams are coming true, and we're in jeopardy of losing our herd immunity to measles, which would be the beginning of a nightmare. But let's hope it just is a problem for California. But that's how things begin. So, since we know that measles is probably the most contagious virus we have, it's a source of concern. John McKenna?
Yes, you mentioned the herd immunity. I'm not sure I understand exactly what that means.
Well, when you have 95% of the population that's immune to the virus, then everybody's immune to the virus. And that's what is called herd immunity. Means that everybody's protected because of the fact that the immunity is manifest to everybody. That's why they call it the herd immunity. And when you have less than 90%, then that so-called herd immunity is lost. And the concern, as we had discussed last week, is that once you have that for one virus, it then lends itself to exposure to other viruses, mumps, and so forth down the line. So that this is a real crisis to try to recognize the importance of as many people as possible being vaccinated, so that those people who cannot be vaccinated for whatever reason can be have immunity as a consequence of the so-called herd immunity.
So that also implies that all of these kids, over 100 kids that were exposed, possibly, they would have to follow up with them and see if they had.
If they have not been vaccinated.
Right.
If they've been vaccinated, it's not a problem. But if any of them have not been vaccinated, then it's a problem.
That's a big job to follow up with 100. Is it 130?
Yeah, that's right. But that's Pandora's box that's been opened up because of our lack of willingness to be vaccinated. So it's a big deal. Very big deal. Dr. Perez?
Good morning, everybody. And it's also the penetration of distrust, because public health is very difficult when people don't I'm the government and I'm here to help you. With a government and a kind of response to this that's occurring now, people aren't going to come in for care. People are not going to tell you the truth about their living situation, who they've been exposed to, because then they are at risk for other types of oppression.
Thank you for sharing. Yeah, so true. Okay, if there are more questions about that, which is the question of the day, and this is the article that shows that mumps is next. Uh, that's another virus that affects the parotid gland that we don't see anymore. But as we lose the herd immunity for measles, we may lose it for other viruses as well, and mumps is next on the line. We haven't had a real mumps outbreak, but it may follow. So this is a concern, and since people haven't seen mumps in so long, may not recognize it, but it involves the gland, the salivary gland, and it's contagious as well. The salivary glands are the glands that are right under your ears, on both sides of your ears, and under them. Darryl?
Yeah, 54% of Americans get their news from social media, and it's particularly those up to age 34. So those are the parents that have the young kids that need vaccination, and they're getting a lot of their misinformation from social media. That's why kids aren't getting vaccinated.
Thank you for sharing, Janice.
That's exactly what I was going to say. Our younger generation, they're not like us. I mean, I think a lot of us at our age now, when we had our kids, it was the norm. You did what the parents said, and you do everything what we thought was the right way. But the younger generation, this new generation, they don't believe in anything. And they think everything is going to hurt you. And if they think it's wrong, they're not going to do it. I know of a young couple who did that and took the kids to the doctors. Oh, no, you're not going to give my baby a shot. And I think it's a lot of them out there like that. And they're going to believe it until something drastic happens.
Thank you for sharing, Janice. Okay. Okay, let's go to the next article. This is a warning that CDC is uh, sharing that polio is in some countries, Spain and UK, other places. So they want to be sure that you have your polio vaccination before you leave the country if you're going to the list of countries that you see down below, because the possibility of polio is there as well. That's a large list of countries. And that's another disease that vaccines have just about eliminated.
I have to say, I mean, this article takes my breath away. We are talking in 2026 about polio.
Yep. Yeah. A disease that most of us have never encountered because of the vaccine. Jonas Salk and others like him. Sabin. Mm. Yeah, well, our new administration is largely responsible. So anybody's going international travel, be mindful. Plus, international travel these days is a little more adventurous than it used to be because America has been doing some strange things across the world. So,
So, Dr. Callender, if we had the polio vaccine, I think, is that the one we got on the sugar cube back when we were kids?
yeah, yeah. So if you,
Is that vaccination good for life, or do we have to get uh,
it's supposed to be good for
polio?
life. Yeah. Um, just want to be sure that you've had it. That's all. Yeah. And
And the
they're recommending,
politics.
they were recommending that if you had any questions about it, that you could get another vaccination to protect yourself. You, Dr. Brass?
I'm going to say polio, we should have been moving towards the eradication of polio globally.
Yeah, that's
From the
true.
same conversation that we had about herd immunity.
Yep.
Was the direction that we are going in, not in this direction.
Yeah, it's clear we're moving in the wrong direction. Now, this article is something that is encouraging that most Americans don't trust the CDC anymore, but that's not a good thing. That's why we have a CDC, so you could trust them, but their behavior recently is not trustworthy, and that's a bad sign. The area that we've come to trust as being the place for good advice is no longer the source of good advice. Dr. Perez, your hand up again? Or oh, you didn't take it in.
No, I took it down.
Oh,
I could go on and on, but
okay. Well, that's what the purpose of this meeting is for you to go on and on. Okay. But I think that with the increasing distrust of the CDC, programs like this become more and more important, especially since the social media is such a source of miseducation and diseducation. So programs like this that educate the community become more important. Any other comments about what's going on? Dr.
I'm,
Price?
I'm
go ahead, Mr. Buchanan.
Yeah, I was going to say I'm surprised that Tylenol didn't sue uh, Trump for putting the name out there like that associated with autism. That's horrible.
I'm afraid of backlash from Trump. Yeah. No. When ignorance is bliss, it's folly to be wise. Whole statement. Go ahead, Lucy.
It, you know, it's real important, even though there's social media. Um, I have to believe and trust that there are cultural and personal things that we can say to people that can change behavior. And I truly believe that we're on this call today so that we are armed with the information to reach the people that we're ordained to reach. And it's a challenge. But I know that there are people who will believe, because I believe things because I've heard it from you. And I've tried it, and I'm better for it. And I know in each of our spheres of influence, we can have that same type of impact.
Thank you for sharing. Any other comments? If not, we'll go to the next article and be pleased that people are trusting other sources when CDC is failing us. This is an interesting article. It talks about 8 common habits that could increase your risk of dementia. We know that Alzheimer's is the commonest form of dementia, but there are many other forms of cognitive loss that affect daily function. But this article identifies some 8 factors, and they start off with food as being medicine, important for your brain health and important for your health in general. What's important for your health? For your gut health, it's important for your heart health, and it's important for your brain health. And they talk about the plant-based diet being superior to other diets for keeping your brain and your heart healthy. Then the importance of managing chronic diseases, inflammatory diseases like diabetes and high blood pressure and other problems. That vascular dementia is another cause of dementia, where the circulation is compromised. As the third is not getting 7 to 9 hours of sleep a night, which seems to be the bare minimum that they recommend. And they identify those with sleep apnea who are not capable of getting good sleep as being vulnerable for this. Then the importance of the social aspects of making time for friends and family as being a very vital aspect. And then drinking too much alcohol. How much is too much alcohol? That's a loaded question. There are those who think any alcohol is too much, but there are those who think that a daily drink is good for you. And then not exercising is not good for your heart or your brain. So not exercising, we've talked incessantly about the minimum need for at least 30 minutes a day, 5 days a week. And that being combined with resistance exercise, along with aerobic exercises. And then they talk about bicycling or motorcycling or any of those things, and even the other thing where you hand carry it. They do that without helmets, and of course, not wearing a helmet is very dangerous. And we see many patients who are not alive because they didn't wear a helmet. And then ignoring depressive symptoms, having extreme anxiety and depression and ignoring it without getting treatment. The incidence of mental problems and people who have depression Another related is also uh, the cannabis users. There's an article we will read soon that suggests that cannabis users have double the anxiety and depression of other people. So these are all aspects of lifestyle changes that decrease the likelihood of dementia. They don't eliminate it. I did have a chance to talk to one of our geriatricians who was going to present to us shortly about the fact that we're now getting to the stage where we're going to have medications that effectively treat Alzheimer's. We're not there yet, but we're getting closer and closer. Any other comments about dementia and ways of decreasing the likelihood of getting dementia? Okay, no comments. Let's go to the next article. This is an interesting article. It may not be applicable to many, but uh, drug-eluting balloons uh, are balloons that go in and dilate the blood vessels. In contradistinction to STEM, where they put in a stent, which is permanent. Okay, and the balloon you put in it dilates the vessel, and uh, it's not permanent. The stent you put in, it's permanent, and it has its complications. So this probably has little application for those who don't have any coronary artery disease. But for people who have coronary artery disease, they can either do the balloon angioplasty, where they put a balloon and dilate the vessel, and there are complications from that. But once it's done, then a stent can be done if necessary. But there's still some controversy over which is better. Each of them have their complications, and it's probably something for your cardiologist to discuss with you in terms of whether you need the angioplasty or the stent. But if the stent is put in, there is a complication of the stent clotting off, and if you do a balloon angioplasty, it's still a possibility of restenosis, but it's less likely than when you have a stent. But anyway, I just thought when you see the term eluting, drug-eluting balloons or stents, that's what they're talking about. Stent is a permanent introduction of something into the blood vessel that allows the continuity of circulation, whereas the balloon dilates the vessel, so it opens and stays open. So anyway, just to educate you about the fact that there are balloon angioplasties and that there are stents, and there are two different types of treatment for the same blood vessel pathology. There are no questions on that. Since cardiovascular disease is the number one killer in the country, and heart disease is, I thought we'd include that. There's an article that says that doctors with chronic pain are much more sensitive to treating patients with pain than those doctors who don't have pain. And it talks about how the sensitivity to pain is important because chronic pain is the most common reason people seek medical care in the United States. And so management of chronic pain leads to many problems. Because of arthritis in the back and upper and lower extremities. People seek pain medicine, people get addicted, and all you have many instances in which people can't work because of pain. Dr. Perez?
And there are lots of bias around pain and the need for it to be eliminated, and greatly so as it relates to race. And it's important for us to be advocates for each other in that arena, to pull out a lot of the bias. So many of the children adolescents that I took care of who had sickle cell disease and who needed relief for pain relief, based upon their race, decisions were made about the severity of their pain. And so I just wanted to, just bring up that long-standing racial bias around pain.
It still persists, and I think that the point of this article is that we as physicians need to be more sensitive to one of the commonest reasons that people come to see the doctor, and be more sensitive and try to help people uh, as they try to get the elimination of pain, which is uh, one of the biggest reasons people seek medical care. Any other comments? As chronic pain is something that all of us will experience at some point. And then we have these many pain clinics and spine clinics and other clinics where we now have anesthesiologists whose their only job is to take care of pain, give spinal injections and other things to try to help people with pain. So the pain management has become a very critical aspect of healthcare. The psychological element is an important one as well. Any other comments about or questions about chronic pain? Betty Blair?
Yes, good morning, everyone. Just thinking about this, back in 2012, when I was having problems with my back, I did go to a pain specialist or whatever you call it, but and they were giving me shots and this, that, and the other, because I just felt like I didn't want to do surgery. But after a while, I thought to myself, I'm just wasting my money because I'm going to eventually have to have this surgery anyway. So I just went on and had the surgery. And I ever since then, I haven't had that problem with my back. So I guess what I'm saying is, um, don't maybe sometimes you're procrastinating to go to the pain people just to get a shot or something but later on down the road, you're still going to have to have the problem solved. So I would probably recommend just going on and having the surgery.
If that is one of the options. For
Yes,
some people,
it's
it's
an
not
option.
an option.
Yes,
Yeah.
yeah.
Thank you for sharing. Any other comments? Dr. Perez?
I appreciate so much what you shared, Betty, because it is a decision. And there have been, I guess, what I'm saying, it's so important to have the patient physician relationship so that you make the best decision for your situation and that you call upon the expertise of your physician, knowing that you are making the best decision for yourself. And there's so many people recently that I've interacted with because of suits and maybe a posture as it relates to social media, that the basic trust or communication between patient and physician isn't what I think it should be. A partnership, a sharing. And I think for our community, it's important for us to get back to that, to demand it.
Mm. It's interesting. You made a comment about demanding it. Actually, if you share it, it's not a matter of demanding. It's a matter of sharing and coming together with a decision that you've made because it's the patient's decision to make or not make. And so to me, demand does not play a part in it. Actually, autonomy is what really matters in the patient's decision. It's our responsibility to share as many of the facts as we can, but the ultimate decisions are made by the patient. Janice?
I can add to that. I have a sister who needs knee replacement. She's been seeing a doctor for about 2 years now, and she's getting cortisone shots. And I think it was every 6 months. I believe now it's every 4 months. Hers is fear. She's had a knee replacement with the other leg. She's had a broken ankle. She's had gallstones or gallbladder removed, something else. So she's had a number of surgeries. So it's fear. But the person who's given her the shots is the surgeon who did the other leg, and she trusts him and she likes him, but she still can't say yes to surgery. Now, Dr. Callender had helped me out on this. You're going to continue to have the cortisone shots. And I know it's been 2 years. Isn't that bad as well? I mean, won't it get to a
It
point
has its
where,
side effects, but it
yeah,
has its side effects. But if that's all that she will allow, I
he's
guess you
told
have
her,
no choice.
yeah, he's told her it's bone on bone. And
Yeah. Well, well,
I don't
goes
know.
back
I
to
talked
autonomy.
to her.
It's her
Yeah,
choice.
yeah,
So,
it's her
yeah.
choice. She
Well,
said she's had enough surgeries, but I truly feel you can do this for so
mm.
long, but when it gets to the point where, okay, now we've got to do this, I'm afraid of the
Well,
outcome.
with our emphasis on autonomy, it's up
Yeah.
to them to decide when they're ready for whatever they're
Yeah.
ready
And I
for.
can tell her another story. I have a friend who had knee replacement, didn't go well. She had lock knee. So that leg, that knee is in a permanent sitting position,
Mm.
that bend to the point where now she wears a thick shoe on that leg. So she had a second surgery in May. It didn't get any better. She had the
Oh,
surgery, went to rehab, a nursing home for months,
no.
and sent her home. And then she was doing the water aerobics or whatever for it. Now she's looking for another opinion on that knee.
Wow.
And
Wow.
literally, she walks with a cane. She's really bent over. Now, I couldn't tell my sister that story.
Mm.
I don't know what went wrong, but I guess these things happen. It's scary. It's really scary.
Yeah.
So much to the point I wasn't on last week. I've been having problems with my knee. And I said, oh my goodness, everybody I know around me having knee replacement. I hope that's not it. Last Thursday, I woke up Dr. Callender. I can barely walk. I decided to go to patient first. I've never been to patient first. But I felt had I gone to my primary care doctor, my primary care couldn't do an x-ray. I felt patient first could. They did an x-ray and he said, oh, your knee looks pretty good. Pretty good. He said it's a little inflamed. And I think he said that's possible arthritis. But overall, it's good. He gave me an ACE bandage and 500 milligrams of ibuprofen, told me to take it twice a day. It still bothers me. Um, Not as bad, and I'm trying not to give into it. I've been walking, the weather's been warm. And I think eventually I'm going to have to go see an orthopedic doctor
Yep.
because my knee hurts. And the
Hmm.
fear is these two examples: someone who's been getting shots for 2 years, someone who has surgery and has locked knees still after two surgeries. So, what do I do?
Well, it's interesting because there's another article on managing uncertainty.
Yeah.
Um, but one of the issues is that each person is different,
Mm,
and what is good for one person isn't necessarily good for the other. So
yeah.
I think you need to get an orthopedic
Okay.
evaluation of the knee, and then have more discussions about it
Yeah.
uh,
Mm,
because I think it's critical because what's
mhm.
good for somebody else isn't necessarily good for you.
Right. Right.
Then you need to know
Mm,
what is appropriate for you,
mhm. And I
whether
know
it's
the answer isn't to continue to take the pills, which I've already, like I said, it's a week today. And so I've already kind of weaned myself away from that. But I still feel some
that's
pain.
the
That,
ibuprofen is what you're talking about.
500 milligrams of ibuprofen. He said twice a day. And
Hmm.
actually, I did take one yesterday, but I'm not doing twice a day. But there's still some pain, not as bad as last Thursday, but some pain. Um, so I'm not sure what it is at this point.
Well, I think it's important for you to get orthopedic perspective on it
Hmm.
to find out what they say about it,
Yeah.
and then after that, then you can have an assessment in terms of whether it's something that's going to be persistent and chronic or just an acute episode.
Hmm.
And that makes the difference because if it's an acute episode, then it'll go away. If
Yeah.
it's a chronic thing, then that's another story. So
Hmm.
you have to, and that's the decision that is imperative. Is it acute or is it chronic? And
Hmm.
uh, after when you know that, then I think you can make a decision.
Okay. All right. Thank you.
Any other comments or concerns? Benny?
Yes. As Janice was talking, my husband was saying, mm-hmm, yeah, that's right, because he has had two knee replacements,
Mm.
but he his I don't really know what really happened, but he he will go and get the surgery, but then when it comes down to the exercise and afterwards to get, to strengthen yourself and get better, he does not like to the pain of bending that knee and making sure. And so where he has had two replacements, he probably was not the best candidate for doing the rehab. So his walking is not what it should have been, I think, after surgeries. But I don't think I'm sure he doesn't have the chronic pain, but he does have the arthritis now. So it is like Dr. Callender said, it's just whatever. Everyone is different in what
Mhm.
you're going to do and what you can stand and
Mhm.
what you're willing to do. But
Yeah.
he did end up, the pain was so severe, he did get the surgeries, but he wasn't willing to do all those exercises and stuff afterwards to maybe give him a better quality of life than he has now.
Mhm.
Thank you for sharing. Catherine, you had a comment?
I was gonna just say I had sciatica for a long time, but I probably was treated for about 3 years. But my doctor took an approach. He was a black neurologist and internal medicine specialist. And he took an approach to surgery being the last thing for me to do. So I had a lot of other kinds of treatments, tension injections. I guess they're called tension. I don't know what they're called, but just, little injections, real tiny injections on the leg that I was having the issues with. I had physical therapy, I had a nerve block, and eventually it got to the point where nothing was working. And so I did have the surgery for my back. And interestingly enough, the surgery corrected the problem with a microdiscectomy. They thought I had a herniated disc, but it wasn't. It was just a little bitty bone from my disc pressing against that nerve. And once I had that surgery, I didn't even have to have physical therapy or anything. I was fine. From then on, I've never had any other sciatica issues. But I would have preferred to have known that that was going to be the outcome of the surgery early on, because at points I was even on a walker for a minute.
Mm.
But I still feel that the approach he took was better than having a surgery with a neurosurgeon that might have paralyzed me. Because that, if there had been any issues that happened as a result, I could have been immobile totally. So, I guess I started out with the orthopedic doctor too. So, I mean, I went from orthopedic doctor to neurologist and then finally the neurosurgeon. But I would have preferred to go through that process and know that this was the last resort than to have done it up front. Even though I did have a lot of pain, I wasn't on painkillers per se. I tried not to take that, but the interim injections and nerve block, all of that stuff did help a lot. And I guess it is dependent on what you want to do. I think it is definitely related more to your lifestyle and what you feel that you can do. And I guess the other thing I thought about was, well, maybe he was aware of some different kind of technologies that were going to be coming up or that were being worked on or whatever for back surgeries, because surgery for your back could be, you know, you could end up having serious problems if anything went wrong. Same like your knees and whatnot.
Thank you for sharing. Any other comments about this? Because it's a subject that is very common. And one size does not fit all. So uh, so it's important to keep that in mind. Okay, if there's no other comments, this is the next article that talks about embracing uncertainty, and that's what many of you have been talking about in terms of what is promised and what do the data say, and how do you communicate that to the patient in a way that they understand what is sure and what isn't, and how do they make the best decision in terms of what is the best treatment available for them. How important is the postoperative rehabilitation process? Uh, many There are many people who after surgery are not capable of bearing the pain that goes along with the rehabilitation process, but yet the rehabilitation process may be almost as important as the surgery in terms of the recovery. So uh, since one size does not fit all, then it becomes important that the patient and the doctor have a complete understanding of the risks involved, and uh, that they're pretty clear on what are the risks involved if they're known, just as well as if they're unknown. Because there are many cases, as Catherine had indicated, in which surgery alone is curative, and there are cases in which surgery alone is destructive, and there's cases where surgery and rehabilitation are the real answer. So one size does not fit all, but it's important that the doctor and the patient be together in terms of understanding the risks involved, and then the patient makes the decision that is something that they feel comfortable with. But managing uncertainty uh, is important in the sense that it's important that the doctor make things as plain as possible to the patient, and the patient understand what the doctor is saying. And that's the misunderstandings that occur are very common, and actually are eliminated by doctor taking more time to explain things to patient in terms that they can understand, and then get the feedback from the patient that demonstrates they understood exactly what was shared. And this article talks about how important it is to have a doctor who is trustworthy and is capable of sharing the facts and taking the time to listen, so that there is no misunderstanding about what the decision is made and why it is made. And so this is an important article because it emphasizes that the doctor-patient relationship is paramount, and that there be no misunderstandings about the risk when there is risk, and then the decision makes I'm sorry, the patient makes the decision that is most compatible with their lifestyle. Any comments about this interesting article that emphasizes the doctor-patient relationship and minimizing misunderstandings? Darryl?
Yeah, I would managing uncertainty. Making that decision, tough decisions to make. Uh, there's some help with artificial intelligence, Chat GPT, Gemini, or Claude. You put in as much information as you can, and it'll give you some recommendations, which may include second medical opinion. But even when you get that, like say if you're using Chat GPT, You could also put the same information in Gemini, see what it comes up with, or Claude. So there's a, it can be very helpful when it comes to making a medical decision or any type of decision.
Thank you for sharing. The role of AI in this, to me, is less important than the doctor-patient relationship, although I think understanding the risk is imperative. Uh, and that's what the chat and the AI can help you with. But I think the communication of what is actually going on and the to and fro is not something that AI is good at. I think you need to have a good discussion with your physician in order to come up with the right decision. And I think the AI is an interesting option, but it's not the one that I would favor.
Dr.
Any
Callender,
other comments? This is a really vital discussion. John
yeah,
Buchanan?
can you maybe talk a little bit about this sentence for big decisions like palliative versus curative therapy, or whether to discontinue life-sustaining therapy? These conversations are really important. Can you talk about the difference between palliative and curative?
Yeah, well, interesting. Just had a presentation on surgical residence on palliative, and one of the most important concepts is whether or not it is what you're doing is curative. Whether what you're doing is curative or what you're doing is something that you're just trying to ease things because you don't have a cure. And when we talk about palliation, we really are talking about identifying what you can do to cure or make things as better as possible. And this brings in also the concept of futility, the concept of understanding what you can treat and what you can't treat. And uh, the palliative process is one that identifies what is curable, what is uncurable, what is futile, what is treatable. And when you make the decision about what is curative, then you move forward in that direction with the patient's consent. And when you get to the point that you find that whatever you want to do is not curative, then you have to be honest about it and share that with the patient so that they can make a decision as to whether uh, there is a point of futility that requires to cease and desist and to then uh, not you go from palliation to hospice, which means that there is no recovery. But you can give treatments that make things easier, even though it's not curative. You can make things easier and more bearable. And that a concept of palliation is to identify that which is curative and that which is not curative, and the therapies that you use to help in both situations. The situation that in which there is a cure and a situation in which there is no cure. Does that help you at all, or
Yes, yes, thank you.
any other comments or questions about this concept? Because uh, as far as I'm concerned, one of the strengths of the AI issue is getting the facts on the table. Uh, And that AI is good at in terms of making a decision as to what is good for you and for your particular situation. I think you need to have, in addition to the AI, the doctor-patient relationship that can help you do what's in your best interest, whether it be curative or not. Any other comments or questions? Because this is a very important concept to understand, which emphasizes who you select as your uh, physician, your healthcare provider. Okay, let's go to the next article. Oh, this is an article on whether this is sildenafil is well known as the drug that is the best treatment for erectile dysfunction. And it is known, it has a higher incidence of retinal detachment. And so the question is it worth the retinal detachment risk? Although the retinal detachment risk is still low, it's still something that is something to be concerned about. So the men who take medication for erectile dysfunction have to be recognize that the risk for retinal detachment is increased. And so uh, and having an eye referral is a good idea as well. Any comments about this ED is erectile dysfunction is a common issue for which uh, this drug is the treatment of choice, and it's very effective. So, uh, however, as with every other drug, there are side effects, and retinal detachment is one of the side effects of.
What are the symptoms of retinal detachment? What does that mean? What happens?
You can't see. Yeah, you have trouble with your vision. Yeah, and so any concerns about your vision, you go to the doctor immediately if you're on sildenafil, which is has been very effective. Darryl?
Yeah, when you get in your 70s, you got to take a holistic approach to your sexuality, which means controlling your weight, managing your hypertension. Uh, if you're doing if you're diabetic, doing all the things you need to do, getting sleep, getting exercise, and you're still not going to feel as strong and as young as you did at 30. So sometimes you need a little help, but that little help can come in the form of you sleep well for 8 hours, you get the exercise. That's going to increase your your sexual ability. And there are some things that you can do that are very effective, such as pomegranate juice and cacao. Cacao is cocoa. Well, it's cocoa when you roast it. When it's raw, it's cacao. Uh, but just brewing some cacao and some pomegranate juice, uh, you could swear that you were 20 years old again.
Okay, thank you for sharing, Darryl. 70-year-olds take note. Uh, okay, let's go to the next article unless there's another comment. Oh, this is an interesting article which gives a perspective that they say that this article is alleging that the hypertensive people have it wrong. They say that what is good for hypertension in men is not the same as what's good for hypertension in women. And the data suggests that women with lower blood pressures have more cardiovascular disease than men. And therefore, using the same metrics for women as you do for men will result in more cardiovascular events, adverse events. And they therefore feel that the whole system is rigged against women in the sense that uh, everything is based upon men's blood pressure, when in point of fact, women's blood pressures should be lower than men's. And that's what this article is all about, that the metrics for women should be lower than the metrics for men, which is not the case in general. We have a metric that says that it should be 120 over 80. And this article is alleging that for women, it should be less than 120. And so they conclude that the AHA guidelines are not good for women and that they should be separated. Dr. Perez and then Janice.
Diversity, equity, and inclusion.
What does
So,
that mean?
meaning that I'm sure we're at this point because more women physicians have gotten into the arena to advocate for this.
Well, that's a perspective. I don't know about that. Maybe it's so. Maybe it's because the the facts speak for itself that women at lower blood pressures uh, have more cardiovascular disease. Might that not be the case?
Yes, but I don't think you'd even look for it if it wasn't the presence of women making those decisions.
Okay. Janice, next.
Yes, as soon as you said blood pressure, I mentioned previously that I was at patient first last week. They took my blood pressure, and then the little paper they sent me away with said my blood pressure was high. Now, I was nervous going in. It was 128 over 62. Is that high?
No.
Now, my average is 120, I think over 80. So I don't know why the 62 was lower, but I didn't think 128 over 62 was a high blood pressure reading. But
Well, it isn't, but according to this article, and interesting enough, this article says that 120 is high for women, but AHA does not agree with that. And that's the point that Dr. Perez was making, that uh, the sensitivity is different. The AHA guidelines would say that 120 over 80 is the ideal. 128 is maybe uh, very beginning of hypertension, but uh, for men it would be okay. This article is saying that for women it would be high.
mhm.
And I'm interested in Dr. Perez's opinion about that because I'm not sure that there's an awful lot of data to support that. But this argument is one that I think will need to be dealt with because there's another article that also points out that women after heart attacks die more often than women, more often than men. So there's an argument that the pressures of women might be better off to be lower than men, but I'm not sure about that. But my answer to your question is that 128 over 60 would not be considered hypertension to me, but
I didn't
was
think
to you.
so. Yeah. I thought
Okay.
that 128 was a little bit higher for me, but again, I'm, concerned about my knee and I'm at the doctor's office. So I thought it was just me being a little nervous and excited.
Well,
But
that's
oh, your
why
blood pressure is high. I said, what?
that's why the most important part of getting your blood pressure taken is the circumstances under which your blood pressure is taken.
Hmm. Hmm.
And so that's why one of the biggest problems of hypertension is that you don't give it the proper time and circumstance to be well rested and it reflect. Because
Hmm.
if you're nervous, then that is a reason why your pressure would be elevated.
Right. Okay.
Catherine?
I was just gonna say, the other question I had is when they did this study, I was trying to pull it up. Did they have, I mean, in general, let's just say that in general, do they always have the same number of women as men when they're doing some of this studies? And I know they don't have the women researchers as much, but the question is, do they have the number of women and men in the trial? I saw, I guess
It's
at the
hard to tell
end.
it's hard to tell in this study. And that's a very important question. But it is clear that they feel that that it's not fair to uh, regard women the same as men as it relates to the blood pressure, and that women fare less well with cardiovascular circumstances than men, and therefore their metrics should be lower than men. But there's no guideline that does that. And so we need to have more studies that address the question you raise as well to answer this question because it's an important question. Dr. Perez?
My hand was, I don't have a question.
Okay. I thought you had some more comment on it. Okay, but this is a very critical new report, and I think it's food for thought. And along with what Dr. Perez has said, it's becomes important to really look at this carefully to see if they are right and that the metrics should be different for males and females, and whether the numbers they have reflect equal numbers of males and females, which doubt. But it's an important question to put on the table. So we'll look out for more work on this subject to see how accurate it is. Okay, let's go to the next article because this is an interesting article that talks about uh, people who have no heart disease who have heart symptoms, having chest pain and uh, shortness of breath and tachycardia and palpitations and fatigue, which are signs of heart disease. But this is found in seniors who don't have heart disease. And so the fact that they find these chest pain and these shortness of breath and tachycardia and palpitations uh, cause them to wonder why. And they did find the patient with obstructive pulmonary disease. Uh, this was uh, common, and so that was understandable. But it doesn't explain the other situations in which patients who don't have heart disease but have chest symptoms. Why is that? And what they're suggesting is that it needs to have more and more study of this category of patients who don't have heart disease but still have heart symptoms. And now this was a study that was done in Norway. So whether it relates to what happens in the United States is another question. So this is a Norwegian study, so it may not be applicable to us here in the United States. Okay, let's go to the next article. No comment. And this is the article I was talking about that in-hospital mortality after first heart attack was higher in young women versus men. Uh, Fitting with the article we talked about that's indicated that cardiovascular disease uh, is more of a problem in women than it is in men, and therefore may require a different evaluation. And this article kind of lends support to the previous article and makes you consider Dr. Perez's perspective of having more women in the field, therefore allowing us to be more sensitive to the gender issue, since we know that women are less likely to have cardiac studies. Studies have demonstrated that clearly. And so the metrics that they talk about may well be applicable. But so far, we don't have all of the answers on that topic. Any other comments? Because this is a very interesting uh, article, which fits in with the previous article about women being more likely to have cardiovascular disease than men. Dr. Perez?
And Dr. Callender, we appreciate this being Women's History Month, that these articles demonstrating the difference and the need for diversity, equity, and inclusion is not missed. So we thank you.
Yeah, well, it's too bad that our administration doesn't share our the importance of diversity, equity, and inclusion, because their role, their effort is to eliminate it, which is a serious mistake. But I don't see any counter to it right now. So, and there needs to be counter to it.
This is counter to it.
But all I see is them taking a strong position on that and doing everything they can to eliminate it. I see no relaxation at all in their position.
There is always pride before the fall.
Pride goeth before destruction and a haughty spirit before a fall. Yeah. Yeah. Okay, let's go to the next article. This is an interesting article that talks about the fact that women who start early menopausal hormone therapy are less likely to have fractures and osteoporosis uh, after 5 years. 3 years didn't make a difference, but after 5 years, there was a significant difference in women who had early menopausal hormonal therapy in contradistinction to those women who didn't have it because they were less likely to have osteoporosis and fractures, which is an important finding because as you get older, the likelihood of fractures and osteoporosis increases. So that's a very interesting finding, and that will be interesting to see if this holds up. Any comment about this observation? Because in the past, many thought that hormonal, uh, menopausal hormonal therapy had its disadvantages. And so many were reluctant to take for menopausal symptoms hormonal therapy. And this then says, hey, maybe it's okay. Not only is it okay, hey, it reduces osteoporosis and uh, hip fractures. Okay, if there's no comment, we'll go to the next article. How many hours of sleep do women really need? And it's interesting because they still come up with the same 7 to 9 hours for women. But they make a comment that uh, women tend to also nap, even if they don't get the 7 to 9 hours of sleep. And that, but for the most part, they're talking about women in the 20s and 30s. But as they get older, the 7 hours is still the figure that is thought to be the most important for the brain to recover as well as for the body to recover. Any comments on this article and sleep and insomnia and Dr. Press?
It's so true because, like the disparities as it related to pain and Black people, I am sure, the myth is that women can do it all.
Yeah.
I went to sleep, my mother was up, and when I got up, my mother was up. The expectation that we don't need the rest, that we don't, this is very, very important.
Well, the expectation is inaccurate because you do need the rest. And it's not good for us to work you to death. We need to share the burden more. The women have shared the burden of racism and everything else more than men. And as a consequence, we have perhaps overcome and won the battle, but their endeavors have been successful, but at what price?
Wow. Thank you, Dr. Callender.
Well, those are the facts. Yeah. What price? Carol?
The thing I like to say is something must be working for women because we still outlive you men. So hard work always doesn't always kill us. But I understand what it's saying. But to relax more and then die earlier, I don't know. Maybe men are relaxing too much, but they do work hard.
Thank you for sharing. I guess it's just, uh, yeah. Any other comments? Important, very interesting article. But it talks about the things you can do to sleep better and avoiding eating close to bedtime and avoiding caffeine late in the day and leaving alcohol alone and other things. But 7 hours is still the figure. Okay, let's go to the next article. Oh, Betty, you had a comment. Betty?
Yes, I did put my hand up and then I took it down, but I will say this, that as a young person, I worked at night, and so my sleeping pattern has always been kind of up and down. You know, I'd sleep a few hours, get up if I had something to do, and go back to bed for a couple of hours. And so sometimes I didn't even realize how many hours of sleep I had. And it carried over even into being older. I still stay up now, even though at one time eventually I got a day job, and I was still, my sleep pattern has never been good, I guess I should say. So I I don't I don't think it has bothered me that much. I guess my body has just gotten used to it, but I've never really had any particular sleep pattern where I sleep long times. I guess maybe adding all my hours I sleep, I might get 7 or 8 hours. But quite frankly, I don't think I do. But but I seem to be doing okay with it, I guess.
Okay. Any other comment? If not, we'll go to the next article. This is an article that talks about plant-based diets are not associated with slow growth in infants. For some reason, there was some concern that vegetarians and vegans, if they started off early, that they would have slow growth, but that is not the case. So this article and an article we had last week both uh, identify the fact that plant-based diets or vegans or vegetarian diets do not slow down the growth. So for those who thought so, that eliminates that. Any comments about this? If not, we'll go to the next article. This is interesting that long-term levothyroxine use may reduce cardiovascular risk for older adults. And I don't know how many doctors put their patients on levothyroxine because of the lower risk for cardiovascular disease, but this is something that some cardiologists have always done. I don't know. I know my cardiologist empirically does it, but and the data supports the fact that those who were on it had fewer cardiovascular events. But I don't know how widespread that practice is. So many of you are not on any medications at all, and some are on statins and some aren't. But I don't know. Are any of you on levothyroxine empirically to prevent cardiovascular disease? It's not something that is done by everyone, but it's something that is done by some. I'll just share that. Okay, let's go to the next article. I guess this is not a surprise that if you don't take the conventional cancer therapy, that the alternatives are not associated with as good uh, cure rates. Uh, Although some would argue maybe there's a bias towards alternative therapies. But anyway, this is particularly related to breast cancer. Uh, and as you know, there's a pretty serious effort to have a kind of a one size fits all treatment for breast cancer with staging and hormonal therapy and the like. Uh, but what they're identifying is that when you deviate from the traditional therapies, that the death rate is higher. And the numbers are pretty staggering. Talking about millions of patients. And then you have some people who do not take any therapy at all, that they don't believe in medicine. So they do not take any of the radiation or surgery or any of that stuff. And the numbers suggest that those who take the traditional ways live longer than those who take the alternative therapies. We have so many women dying of breast cancer that it's painful to see how many young Black women are dying of breast cancer. You have many women who don't take the conventional, traditional cancer therapy of radiation, surgery, and the like. Dr. Perez, have you had much experience with that?
A few, not personally that I took care of, but um, many friends of my daughter. So I guess younger, middle aged Black women, and some of the horrors associated with health insurance. And depending on where you live, uh, what is available to you. One woman, in order to complete her therapy, had to buy a new insurance because she wasn't covered on another insurance. So it has become a major issue and a political issue as we go into this next term.
Thank you for sharing. Okay. And this is the final article that shows cannabis use is associated with more anxiety and depression, double the rate of anxiety and depression for those who use cannabis. And the cannabis users are usually the younger group. But I think this is one of the first studies I've seen that shows this association of cannabis and anxiety and depression. Uh, but this is a study of Canadians, so I don't know whether it's applicable to Americans. Dr. Perez, you had a comment, or is this? Oh, okay. Okay, this is the last article we have time for. So thank you for attending and thank you for your comments and